the session. So there we go. On screen right now is some information on how to connect to audio and video, as well as to mute. And if you do wish to receive a CME or CEU certificate, we send those out once a month, the month following the session. And so for everything that you do this month, you'll get next month. So if you do want to receive one of those for today, then you do need to announce your name. We'll have a roll call here in just a moment. And if you're unable to use your audio, then feel free to use the chat box. And just let us know who you are and where you're from. And if you do not wish to answer a question that we ask specifically of you, you can say pass. And once again, how to connect to video and audio using those big icons there. And if you do need to join by phone, you have that option. Just click on that up arrow next to the mute, the little old-timey microphone. Our disclosure and accreditation statements are on screen now. Those are required for giving out CMEs. And we do have a partnership with Molina and Blue Cross Blue Shield that if you bring one of your cases to us and consult with our expert panel, then you can be reimbursed by Molina or Blue Cross if your patient is with one of those entities. So it's well worth the time, and we do actually, that's a big part of AHI New Mexico for the certificate program, and we do have one of those coming up in April.
The last chance.
Last chance to get those in. So if you want to get those in, just get in touch with me, or if you have Carol's information, get in touch with her, and we'll get you the information to fill out. There is a big form to fill out. You don't have to fill all of it out though, so don't be intimidated. So now's the time for roll call. If you are able to, go ahead and unmute yourself and let us know who you are and where you're from. It's a little too early yet this morning, I think.
We know you're out there.
So I've announced myself already, so I'll go ahead and hand it over to Carol Conley, the facilitator for AHI.
Good morning, everyone. And before we start, I'll go around the table and let people introduce themselves so you know who's in the room with us here at Studio Envision.
Hi, I'm Jane Beckley, and I'm a nurse practitioner working with Fronteras here at Envision, New Mexico.
Hi everyone, good morning. My name's Emma. I'm an MSW intern here at Envision New Mexico.
Good morning. My name is Maya Trujillo. I'm a quality improvement specialist here at Envision New Mexico.
Hi, I'm Holly Jenkins. I'm also an MSW intern.
I'm Rosanna Abisha-Oliva. I'm a pediatric intern at the University of New Mexico.
Good morning. I'm Vani Parashetty. I'm the pediatric resident too at UNM Children's Hospital.
Welcome.
And my name's Lisa Morad McCoy. I'm a clinical social worker, and I work at the School-Based Health Center.
Chris Carrillo. I'm also a clinical social worker, and I'm in the School-Based Health Center program.
Okay, we do have Daniela from First Choice Alameda and Sandra Byrne from Shiprock. And that's all I've heard from so far, but I know there's a lot more out there. So
chime in if you want your CME or CEUs for this presentation. We'll be glad to provide those for you. So once again, good morning, everyone. Welcome to Studio Envision. I'm sorry? I heard something out there?
Hello, I'm Richard Stam. I'm a retired pediatrician.
Welcome, thank you. Okay, without further ado, we are here today to talk about depression and anxiety in adolescents. We are very pleased to have Lisa Morad McCoy, clinical social worker here in our UNM School-Based Health Center programs. Lisa has about 15 plus years of working with adolescents, and she knows a lot about this topic she's going to share with us. So I appreciate you taking the time to come do this talk, and without further ado, we'll get started.
Sure. So actually, my presentation is, the PowerPoint is depression and suicide in adolescents. Depression and anxiety sort of go hand in hand, so we'll talk about both as well as suicide assessment in adolescents. And as you can see, I'm a clinical social worker, and so my lens is as a social worker, which is very community and family oriented. So a lot of this presentation is going to also talk about work with family and community for adolescents and how you can bring that in. So first we're going to talk about some statistics. Some of them are a little bit depressing. And then we'll go on to signs and symptoms of depression and suicidal ideation, as well as anxiety. And then we'll talk a little bit about assessment, and really tailored to teens so that you can talk to teens in a way that they can understand. I think a lot of times what happens with adolescents is they don't necessarily even understand the questions that you're asking when you're trying to assess for depression or anxiety. And then for treatment, we'll talk a little bit about some treatment techniques for depression and anxiety, more in terms of therapeutic treatment, but we can also talk about some brief treatment as well, and then we'll talk about resources. So if there are any burning questions during the presentation, you can go ahead and interrupt me. I will have time for questions at the end, but it would be great to just also have a discussion about this too, because I know this is geared towards depression and suicide, but I want to bring anxiety into it as well. Okay, so some statistics. This is from the New Mexico Regional Mental Health Report. Kids who have planned suicide, so that's made a plan, suicidal ideation in the past 12 months, that's pretty close to the national average. So the U.S. is pretty close. New Mexico is pretty close to the U.S. in terms of that. And then youth who have attempted suicide, it's a little bit higher in New Mexico. The statistic that is concerning, and these are old, they're from 2009 to 2013, but per 100,000 youth, New Mexico, of the children who have died or of the youth who have died, we're about double the national average, which is somewhat sad, very sad. And so a lot of the work in New Mexico has been around prevention of youth suicide, and especially prevention of depression and anxiety, and education around depression and anxiety for adolescents and their families. What I have found in practice at the schools is that a lot of teenagers just don't even know why they're feeling the way that they do. And families don't know why their kids are struggling. And just a little bit of education can go a long way to preventing suicide. So again, and a lot of you probably know this statistic that girls are more likely to attempt suicide. So the more girls attempt, but of the kids who attempt suicide, more boys actually complete suicide. So boys are actually very high risk when they come in with symptoms of depression and anxiety that are really acute and chronic. So we really want to watch boys especially. Girls tend to act out and tend to do things like take pills or cut themselves, which doesn't always end in a suicide. Boys are more likely to use firearms or other weapons. So we just really want to watch boys carefully. And then these are some risk factors that go along with depression and suicide. If you have a family that there's a history of substance abuse, there's a history of suicidal behavior, a friend, I don't have this up here, but a friend who just committed suicide that's in a teen's life, those kids end up being very high risk, especially if they're struggling with depression themselves. And obviously access to firearms and stressful life events. And especially in this time right now, this is the 1 month past the Florida shooting in schools, you see a high instance of increased depression and anxiety symptoms during a period like this, where there's been a tragedy or a trauma that's happened that is very close to teenagers. So this is my main resource for the statistics, the regional mental health report. So symptoms of depression: feeling sad, angry, tired, social withdrawal, hopelessness, change in habits, sleeping and eating. So the one that I see the most, I would say, I see about 25 to 30 kids in a school-based setting, maybe more, during a particular semester. And I see social withdrawal more than any of these. Because so when kids are feeling down or even anxious, they tend to pull in and stop doing things that they used to like to do. So if they used to, I had a girl at one of the schools that I'm seeing, she used to love color guard and just kind of very suddenly just stopped and decided that she didn't really care about it anymore. So when a kid is doing something like that, stopping activities, that's a big red flag for depression and anxiety. And what I'm seeing in terms of anxiety is a lot of social anxiety. And I'm going to talk a little bit about this here because I really think part of what I've seen is that kids are very influenced by social media, obviously, and so they're getting their social life is existing in social media. And so when things don't go well on social media, that they start to become very socially anxious, and they withdraw both from personal relationships, in-person relationships, and from social media. And a lot of these kids that I see don't really know how to socialize as well, and they get very anxious socially, even talking on the phone. So that's one thing. And then with symptoms, you just see a lot of them increase as their symptoms get worse. So depression looks different in teens. And a lot of times I always use this example of teens of Eeyore, of this kind of dysthymic depression where it's just this low-key, everyday depression. And I see the kids that I see, a lot of them struggle with this. It's very chronic over time, especially in families where there's been a lot of trauma, substance abuse, and also just poverty and financial stressors. Okay. So signs and expressions of depression. So nothing is fun anymore. They say things like, I just don't care. They stop their clubs, music, sports. I had this one young lady who at one of my schools was very involved in several activities. And then one day she just came in for a session and said, oh, I'm stopping drama club because I just don't want to do it anymore. And I think I'm going to stop Senate because I don't really care about it. And she was saying it in this very matter-of-fact way, but it was also very sudden. And so we explored what was going on, and this is a kid who hadn't necessarily had that many symptoms of depression. Her symptoms were more anxiety, but then it just turned out that she was really struggling with depression and didn't know how to name it. And that's one of the things that you see with teens. They just think that something's wrong. They think that nobody else is struggling with what they are struggling with, and they think they're the only one. And they also, many of them think that their families are going to be upset with them or angry with them if they express how they feel. So complaints from teachers about behavior, and especially to a drop in grades. That's a big one too. So with suicidal ideation, the symptoms are the same. There's a preoccupation in some cases with death and dying. Low self-esteem is a big one for suicidal ideation. You want to watch that because kids who feel bad about themselves and don't have what we call protective factors, they don't have at least one adult who's pulling them for them and caring for them, and that they feel comfortable expressing themselves to. That's a big risk factor for kids that are depressed and anxious. And many kids, you'll see anxiety with suicidal ideation as well, especially if they're thinking about their own death. And a lot of them have anxiety around what their plan is, what they're going to do. There's kind of this tension and anxiety around the possibility of them actually ending their life. I have one person that I'm working with right now whose father died over the summer, and he has preoccupation with his own death. And he's not suicidal at this point, but this preoccupation with death and dying is very common and can lead to a lot of anxiety in teenagers. If they have a parent who's ill, they worry about their own illness. If they have a friend who's ill or sick or maybe dying, they worry about their own sickness because, as you all probably know, in adolescence, there's a focus on the self more than anything else. And also, so when you see, and then isolation is a big one. If you see a kid who is maybe normally more involved and then slowly starts to isolate themselves, that's something to watch for. So, suicidal ideation for adolescents. So some of the things that they'll say, they're not going to come in and say, I'm going to kill myself, but they do say things like, I don't want to be here anymore, I'm done. I feel like a burden to my family. I hear that a lot, that things would be better for my family and my friends if I wasn't here. And I had this one teen who started giving her stuff away, and that was a big red flag for me, and that teen ended up being admitted to the hospital. Giving things away is a very big red flag because they've come to the point where they've decided, it's almost like once they pass that anxiety of deciding whether they're going to do this, then there's a calm that sets in, and they calmly feel as though they can give things away and separate from their life. So writing a plan or images of the funeral. And this one is often a sudden burst of energy following severe signs of depression. That's a hard symptom to, I think a lot of people miss. So you have to see a kid for a long time. So you have to be a family member that sees a kid for a long time, and they may be super depressed, really dysthymic, really low energy, and then sort of suddenly they just start feeling better. And families feel like, oh, he's getting better, or she's getting better now. And really that can be a sign of possible suicidal ideation and completing a suicide, unfortunately. And if you see, so for anxiety, if you see a super anxious kid that just all of a sudden calms down, and that calms down and has a sense of almost like calm and well-being, that's a red flag as well. Okay, so we're going to talk a little bit about assessment. And then after we talk about assessment, I'll pause for a little bit for questions. But So the biggest issue, and I think in terms of assessment of anxiety and depression in primary care, is asking the right questions and asking questions in a way that teens can understand. Because they're a lot like little kids in some ways, and especially middle schoolers. They don't have a sense of time. We think that they do, and some have a better sense of time than others. So getting the answers you're looking for, that's just what I just spoke about. You have to really put things in context and give examples of thoughts, feelings, behaviors, use ages, holidays, relate a lot of your questions to school, to the start of school, to the end of school. So some do's and don'ts. Have you been feeling this way for more than 2 weeks? They don't know what 2 weeks is, right? Many of them don't. I shouldn't say all, but many of them are, when you say 2 weeks, they don't really understand what that time span is. Or if you say, how long have you been feeling this way? They have a hard time with that question as well. So the way I do it is I ask things like, have you been feeling this way since school started? Or since winter break, middle school, elementary school, homecoming and prom, although I don't really use that much. But I also use, like if I know a kid has moved, I'll say, have you been feeling this way since you moved to your new house? Or just bringing their life in context. Okay, some more do's and don'ts. Have you been irritable or having feelings of hopelessness? First of all, that question, they don't necessarily know what irritable means, and they definitely have trouble with feelings of hopelessness. So I give kids a lot of examples. Have you had a fight or an argument? And I'll paint pictures for them. Have you been, talking to a friend and then all of a sudden you get really irritated and want to punch them in the face? And I try to make things really kind of colorful for them to see their life in pictures and understand what irritability is. Or have you ever thought to yourself, I just don't care about school anymore. I just don't want to go. So really try to think of context. So internal and external environments for both depression and anxiety. Internal environments occurs obviously within the mind. So you're talking about thoughts, feelings, and thoughts and feelings essentially. Have they been sad, nervous, afraid, angry? And the thoughts kind of fall into two categories with depression, and the depression can actually cause anxiety. So thinking of yourself as either unlovable or incompetent. Those are the two main, if you have to put kids' thoughts in two different categories, they usually feel unlovable or incompetent. And that's for adults as well, actually. And if you can kind of, as not necessarily in primary care, but as a therapist, if you can kind of help them see that divide and help them see, like, these are thoughts that you don't like yourself, and these are thoughts that you can't do X, Y, or Z, or you think you can't do these things. And they're also their perception of protective factors. So I have this child that I'm working with now who actually has some really wonderful, loving, supportive parents who have struggled in their life. And so in the past, the parents have had substance abuse and have been verbally abusive, and it's been difficult. They've had homelessness, but they've really turned themselves around. And this teenager, who's also developmentally delayed as well, she is very stuck right now on the fact that her parents, she uses the word damaged her when she was younger, and so now she can't forgive them, and she doesn't feel connected to her parents. If I was looking in as a lens to this family, and I saw this family interacting with this child, I would say this kid has these really supportive parents, but the kid doesn't feel that way. So their perception of their protective factors is really important. Okay, so the external environment, the world the teen lives in. It's really hard to see teens in a vacuum. In primary care and in therapy, as much as you can involve family and to understand what this teenager is going through, the better you're gonna have a better assessment. So again, family, school, friends, and protective factors. And I'm saying protective factors over and over again because if you have a teen who's super anxious, super depressed, and maybe suicidal, and they have really decent protective factors, that teen is going to do well eventually. It will eventually get to a point where their protective factors sink in and they start getting better. It's the teens who don't have any protective factors, who are homeless, who are abusing substances, who feel alone in the world, who've had death in their family. Those are the kids that really struggle. So those are the kids I really try to watch out for when I'm working with them. So again, get family input and collateral whenever possible. So this is through a social work lens, this presentation. And social work is based, and this PowerPoint is actually a PowerPoint that I did for a class of social work students, and so that's why it's very practice driven, but it's through a social work lens, and social work is based on person and environment. So it's really difficult to understand, I believe, teens and kids without having family history. Family can help you understand the teen's depression within a context. You can get a lot more information quickly from family than you can necessarily from the teenager, because it might take a while for you to understand that a teen has been depressed ever since they were 5 years old. Where a family can say, oh yeah, this kid has always been this way, and I'm not really sure how to handle it. I never really have been. A family can also tell you about past trauma and a history of depression in the family. When you ask a kid, does your mom have a history of depression or anxiety? They're like, I don't know. So parents and caretakers can really be helpful in this. So assessment tools. I use a lot of assessment tools working with kids. When I first started working in the school-based health center about 5 years ago, I didn't like these. I was really kind of snobby about them. And I thought, well, I know when a kid's depressed. I don't need an assessment tool to decide when a kid is depressed or anxious. But when I started using them, I realized that they are marvelous teaching tools for kids. And in primary care, I know it may feel like you don't have time to do an assessment tool, but PHQ-9 and GAD, the PHQ-9 is to assess depression, and the GAD is to assess anxiety, and they're very short, okay? And they can be done pretty quickly. The SCARED is longer. The SCARED probably takes about 10 to 15 minutes to complete. But I actually have grown to love these tools, because when I'm sitting there with the kid and analyzing the assessment tools, they get so excited about it. And I was doing work with this one very anxious child who really wanted to know her anxiety score. And really, so we did the scared, and she got a really high score. And then she was pretty upset about that, but was asking all these great questions about anxiety and what it means and how long will she be anxious, and wanted a lot of answers. And then when I said, okay, we're going to take this in 3 months and see where you're at in 3 months, she was right on it. I think on the day of the 3-month mark, she was like, can we do that test now? And I think part of it is because kids are so test and grade oriented that you don't necessarily want to encourage that, but that's what they understand. And so I just find it a really good teaching tool. So if you have access to these, I think, and you have the time to do them, I think they're really helpful. Okay, so suicidality assessment. You want to know, is there a plan? What is it and how detailed? And do they have a means to carry out it? So means and access are the biggest 2 issues with suicidal teens. And the other big one are the protective factors. So if a kid has really high protective factors, and even if they have a plan, I'm not as worried about that kind of kid as I am worried about a kid with a plan and no protective factors or very little protective factors. There's assessment tools for suicidality, like the Columbia assessment, and then also there's a risk assessment too. What studies show and what research shows is that those assessment tools are not very good at predicting whether a kid is going to commit suicide or complete a suicide. So just be mindful of that. And talking about anxiety, again, the biggest issue with anxiety is if you have a super anxious kid who just all of a sudden calms down, that's a red flag. And you want to explore that with them. So protective factors, future goals. If a kid can tell you, oh yeah, I want to go to college. So I may have a super depressed, anxious kid who just seems like they're really struggling. And then I ask, well, what do you want to do? What's the next step for you? And they say, oh, well, I want to go to Arizona State University and I want to take these classes and I want to become a marine biologist. I don't know why they would go to Arizona State. It just popped into my head. I'm not as worried about a kid like that. If they're just like, oh no, I don't really care. I don't really think about it that much. That's more concerning. So family and friends to care for, if one of the first things they say is, well, one of the questions I ask is, what's going to stop you from doing this, from actually carrying out a plan? And if they say, if they just right off the bat say, oh, I need to take care of my mom, or I need to take care of my little sister, or my mom's sick and I need to make sure that she's okay, I'm also not as worried about a kid like that. So, and then a history of resilience. So kids who have shown that they've pulled themselves out of sadness and anxiety in the past, and supportive caretakers. And supportive caretakers, this isn't just parents. It's even if they have a really good bond to a teacher or a coach, if they feel really connected to at least one adult, that's a really important protective factor. Okay, so I'm gonna stop right here for a second. Are there any questions about assessment? And please ask, if you have questions about anxiety, please ask me, because I know this is very depression heavy. Are there a lot of you out there in primary care? Yeah.
Looks like most people are in primary care.
Okay.
All right. This isn't specifically about depression or anxiety, but I was thinking when you were talking about trying to get family input, how do you balance the issue of confidentiality? I mean, I know that confidentiality doesn't apply where there's an imminent risk.
Right.
But what about the kid? I mean, you want to engage them. You want them to feel like they can be open. And so where do you go with that?
So it depends on the context. So I'm imagining that in primary care, like in a physician's office, and I've seen Sean do this before. Sean is a nurse practitioner that I work with at one of the schools. If there is an imminent risk, she'll get the family on the phone and, do it that way. The other way is to see a kid over time, and at first they're like, I don't want my parents to know anything ever. But then over time, if you introduce the idea of, well, you're really depressed and you're doing some cutting, I think this is a good thing to tell your parents and do some education about, parents do not always react in anger, and you'd be surprised how supportive they can be. And getting kids to see that, because kids are they're so hyper-focused on they're going to get in trouble. Our system in school is so discipline-focused and so punitive, that kids are always worried they're going to get in trouble. And, Sean, I think, and I do too, does some education about nobody can punish you for your feelings. This is not about, and if they have a really disorganized family and their family isn't going to be supportive, then you drop it. You don't introduce the family. But if there is a supportive family, like this kid that I was talking about, so what I did with this kid who has this really negative perception of her family is I got her to a point where she said, okay, miss, you can talk to my parents and we can bring them in. It just took some time. So you never want to breach their confidentiality, unless you have to. But if you can just jostle them to the point where they're okay with meeting with their family, you bring the family in. And the family was wonderful in the sessions that, we were together, and we talked about some stuff and processed. And things got better for a while, because when kids feel connected to someone, and especially their family, they get better. So it's not an easy, if you're a one-stop shop doctor who, sees a kid once every year, it's going to be hard. But if you can find a way to see kids over time and get them to a point where they're okay with telling their parents, then they usually are. And because kids, deep down, they want connection with someone, with their family.
Sometimes a student will ask you, say, I'd like to have your permission to talk to your parents. And the first question I get back is, are you going to tell them everything I said? Well, no, absolutely not. I'm going to ask them, what are their concerns? Maybe we can talk about themes, what they're seeing, So it's really, I think they're worried that because they said their little brother was a total loser, I'm going to report that, to the parent. And it's like, no, that's not what this is about. And once again, it's like they're going to get in trouble.
Right. Yeah.
So.
Anything else?
We did have a response from Sandra Barron to your question that yes, I do primary care in a clinic, but primarily at schools and dorms.
Okay.
And our mix so far is a mixture of MA, a couple of physicians, therapist, social worker, and a few I don't know.
Okay.
Yeah, so it's a mix.
Okay. Any questions about anxiety? Because I feel like this is depression focused.
I have a comment about some of the assessment tools.
Yeah.
The SCARED, I find, especially with middle schoolers, it always stimulates a conversation because it's fascinating, but to them. And part of it is if you go over, if you're doing it on the iPad and the alert report pops up, it really helps. It really kind of separates it into the different kinds of anxieties kids could be feeling. And that's really helpful, whether it's, kind of panic, whether it's social anxiety or anything in between. It gives you a little bit of a handle on what is this kid experiencing? Is it performance issues around grades? Is it, and then you can, there's a buzz.
Mm-hmm.
Is
it you?
Yeah. I must have said something I'm not supposed
to. And just to say a little bit more about that, what I'm seeing with the scared is so much social anxiety. I cannot get across how much social anxiety I'm seeing because, and this is just anecdotal, it's my own theory that they are, they're on electronics all day and they are on the computer or on their phone, and their social life is social media and Facebook or Snapchat and Instagram, and they see that as a social life. And that's where, I'm dating myself, but it's really hard for me to see that as a social life for kids. And I'm trying, I really am. But I talk about it a lot with them. So it took me a long time to realize that when there's a status on social media that's meant for a huge group of kids, they take it personally. It's about them. It's not about, because I'll look with them and they'll say, "Miss, look at this. Look at what this person wrote about me." And I said, "Well, that looks like it's to like a ton of people, not just to you." And it's this really distorted view of social interaction, I think. And one of the things that I try to get them to do is have personal conversations with people. Like I'll say something like, "I want you to have a conversation with one person this week." And it's really amazing how much anxiety that provokes. And so with anxiety, you have to do some exposure where you get them to think about how it's going to be to talk to someone, how it's going to be to ask someone a question. So that's one of the struggles that are out there.
Quick question.
Yeah.
I may be the only one, but can you tell me where to find SCARE? Because I'm not that familiar with it.
It's a public domain. You can just Google it, and then you can get the questionnaire, and it's not, none of the tools require any particular expertise in scoring them. They're self-scored, and then gives you the range, and then it's kind of, you can create a conversation around what some of the scores are in the different categories.
If you're in primary care and you don't have a lot of time, I would also use the GAD because it's shorter. And I just like the SCARED because of how Chris said it splits it out into the different types of anxiety. Okay, so with treatments, techniques are great, but if you don't have some kind of connection with a kid, it's going to be really hard to get them to do anything. So, cognitive behavioral therapy is really good for depression and anxiety. It's kind of the old standard, and it really helps kids connect thoughts, feelings, and behaviors. They have a hard time with this. They don't. So I would never expect a teenager to come in and be able to do this right off the bat. They have a really hard time, because I'll ask them, "What's a thought that you're having?" And they'll say, "Well, I'm frustrated," or "I'm sad." So that's a feeling. And to do a lot of education about splitting those out and saying, "Okay, when you think this, when you think nobody likes me, what is that? What what happens when you think that? Oh, I get sad. And then what do you do? Oh, I sleep all day because I don't want to think about it. And so really trying to get them to connect those. That can take a while. But once they're able to do this, doing work with them becomes easier because they're able to label their feelings and talk about their thoughts kind of in a more coherent way. Dialectical behavioral therapy is one of my favorites. DBT. It helps with just in general emotional regulation. Teenagers, like toddlers, have a really hard time regulating their emotion. So they feel a feeling and they don't know what to do with it. And they think that that feeling is going to last forever and never go away. So DBT teaches kids and adults that feelings are very changeable. And just because you feel a certain way, at 10 o'clock in the morning, doesn't mean you're going to feel it at 10 o'clock at night. And mindfulness is all the rage right now. And all mindfulness is, the way that I see it for teens, is basic acceptance of your feelings, acceptance that this is the way I feel right now in this moment, and I don't have to judge it. I don't have to put any labels on it. It may change, it may not, but it's okay to feel this way. Because so many kids will, they'll feel sad and then immediately get anxious about it. Like, I'm always going to feel sad. I'm never going to feel any different. Life sucks and everything is horrible. And to just kind of get them out of that catastrophizing with DBT is really helpful. Distress tolerance, helping them identify times when they were able to tolerate stress in the past and how they got through it. And saying that whatever you're doing is fine right now, and these are the things that we need to work on. So that's the dialectical part. I'm going to accept how I am now, and these are the things that I need to work on. And then interpersonal effectiveness goes back to the social anxiety. Once kids feel interpersonally effective and they feel comfortable with other kids and talking to people, they get better. They have a lot less anxiety. And a lot of it is just education and encouragement and helping them realize that they can get through social interactions and be okay. So mindfulness, just what I said, it's paying attention to the moment that you're in, non-judgmentally. And as adults, we do this all the time. If you're feeling crappy in the morning or crappy during the day, we judge ourselves for that. And it's really important to try to stay away from that as much as possible. So here's some resources. So these resources, and I know they're just hotlines, but the way that I've used these, because in primary care, I think we get really anxious about suicidal kids. And a lot of providers in primary care who see a kid only once in a year or, once every 6 months, the kid talks about suicidal ideation. And the provider is sort of left with, well, what am I supposed to do about this? This is, and they don't have much of a tolerance for suicidal ideation. But so the piece is assessing for a plan, assessing for access and means. But you can also give families these crisis lines. And they're not great. They're not, they're good for what they are. They're good for resources in the middle of the night. But if you talk to a teen and say, you know what, if you wake up at 2 o'clock in the morning, you can call this hotline and somebody will be there to talk to you. And then they have a link to more resources. So try not to completely, because I've done this in the past where I'm like, oh, it's just a hotline and that's not going to do anything. But I think they're actually very valuable in this world of primary care, and can make us feel, like we've at least attached this kid to a resource.
Kind of an anchor.
Yeah.
Mm-hmm.
And so that's it, isn't it? Yeah. So are there any questions, cases, discussion? I don't know how much time we have.
About a little less than 10 minutes.
Okay.
And we'll see if anybody chimes in. Any questions around the table, thoughts about Lisa's presentation? Something you want some more? Mm-hmm.
And if anybody needs more resources on anxiety, especially, I have them. I'd be willing to send them to you.
I have a question. So I always thought that anxiety and depression kind of fell into the same category. I always thought anxiety was a part of depression.
Mm-hmm.
Is that true? Is there any relation between the two?
Yeah. So anxiety and depression are they hold hands. Mm-hmm. They're like, and so depression can cause anxiety, mm-hmm. and anxiety can cause depression. And sometimes it can be difficult to figure out what came first. Mm-hmm. Because what happens with the super anxious kids and untreated anxiety, that these kids have been anxious for years, then they get tired, and it's almost like their brain burns out and they become depressed. Kids who are super depressed tend to, over time, they get a lot of negative feedback for being depressed all the time. And they have a lot of fears that aren't necessarily processed, and so they kind of become anxious, and then they have both of them together. That's why there's so many diagnoses like depression and anxiety. There's a ICD-10 code for that. It's together. But helping kids understand this is anxiety, these symptoms are anxiety, and this is more depression, and that I use images like they hold hands, they're like best friends, they hang out together, and they understand that.
You can try to frame it for teens, especially if you think it's, if you frame anxiety as, it's really kind of looking at two areas: the inability to relax and the excessive worry. And sometimes that helps them kind of think about kind of what they're experiencing. And similar depression, just kind of simplified for a teenager, would be, lack of pleasure. And I think what I love about your presentation, Lisa, is how you give us different ways of asking those questions and reference points for teens. So lack of pleasure and excessive sadness. And they can really, those words will resonate with them. They understand what it is to feel sad. They might not understand that they're depressed, but it kind of gives you a kind of a foothold, and especially in primary care.
Is there anybody out there in Zoom land? Any final questions or comments of Lisa while we have her here?
Beth is asking, can you recapitulate on protective factors, please?
So protective factors are, the biggest protective factor for teens is one caring adult who is connected to this kid. If it's a family, if it's caretakers, that's great. But even if it's a coach, a teacher who is really connected to the kid, that's the biggest protective factor, and it's the biggest predictor that this kid will end up doing okay. Other protective factors are internally with the kid. Does the kid have future goals? in mind. When you ask them about their goals, do they say, I don't know and I don't care what I do? Or do they say, I want to go to college, I want to get married, have kids, have a partner? The other thing that just reminded me, I wanted to say a little bit about transgender and just sexual identity issues and depression and anxiety. That is a big risk factor. So kids who do not feel like everyone else are very high risk for depression and anxiety. I should have said more about that, but I want to say that really quickly. But so protective factors are internally and externally. And then also their own resilience. Have they been resilient in the past?
What are your insights into why the New Mexico suicide rate is so much higher than the national average? Like the resources or
Yeah, I mean, I don't know specifically. When I saw that, I was like, shocking. Yeah. And I kept looking at it and kept going back and trying to make sure it was correct because it just seemed so high. But I think it's a combination of factors. I think, we're actually a really rural state with lack of resources and a lot of intergenerational poverty, like poverty that's lasted forever, and substance abuse. And I think all of those things come together, and these kids are born into depressed families. And, I can't say enough about poverty. It's really just, kids start thinking that there's just no hope for them. And I think that's why New Mexico is so low. I don't know specifically, but that's what
I think that's
to say.
a really good assumption. And I would also say there are things we deal with in New Mexico, like the historical trauma, that we have yet figured out how to address constructively and, progressively to help people put some stuff in context. And it just kind of sits there.
Perpetuates.
Yes. Over and over and over. Yes.
Yeah. And if you think about epigenetics, one of the providers that I work with is very into epigenetics. Like, this is something that is kind of evolutionary and it's created over time. So depression and anxiety are hereditary, yes, but they're also environmental. And then, so we give birth to depressed kids and kids who are in utero who have stressed out families and stressed out caretakers. You're going to have stressed out babies.
That makes sense.
Yeah.
Thank you.
I think, Lisa, that was what stuck out to me too about being important in utilizing bringing the family together collaboratively, especially I think my experience has been in the middle schools that you see these kids are so dependent on their families and they haven't quite reached the point of like their own identity yet. So many of those factors can be tied to like what's normal in their family or what they're seeing in their home environment too. And so kind of getting a lens for what that looks like at home as well. Like if you can kind of do a mini assessment of what's happening for them at home too, that can provide really helpful perspective about why the kids are functioning that way too.
Definitely. Yeah. So important.
Well, we are at 9:00.
Okay.
Thank you so much for your talk. It was very informative. Thank you everyone for signing on in Zoom land. Thank you for joining us all around the table. We really appreciate it. It's nice to have a group together. And I hope you all have a fabulous rest of your week. See you.
Thank you.
Not next week. There's no Adolescent Health Initiative. We'll be back the following week. Thanks very much.